Hi, everyone. Thank you for the introduction. Whoops. That's my last slide. Okay, actually, with Stefano, we agreed upon the fact that he would complete everything there is to add regarding processed EEG. Well, what I will be speaking about will be the consensus that we performed and why we have performed this consensus. The consensus, however, is still in a reviewing process, so I will not be able to get into precise detail. Anyway, why the consensus? Fortunately, there is a lot of material out there which can help us have an initial approach towards the use of EEG monitoring within the intensive care environment. And also, thanks to some of our colleagues who have published papers which uniform even the terminology that is used regarding EEG monitoring. That also helps quite substantially. It has helped. And this has permitted, like I said before, many of intensivists who have not used EEG within the intensive care environment to closely approach this technology within the neuro, but not only, also the general ICU. And unfortunately, despite this, although there is a high inter-rater agreement regarding the use of EEG, it's still not perfect. There is still a lot of work to be done. We know that, and as a matter of fact, there is no actual gold standard for an EEG's true interpretation. And while the findings of the EEG described with the standardized terminology, the skill of the EEG interpretation is learned primarily from our teachers in a master-apprentice format. It's necessary, though insufficient, a condition for accurate EEG interpretation, which is defined as the inter-rater reliability. And we know that in the papers published showing that the interpreters do not always agree themselves on when looking at a review of interpretation of EEG traces, and that could lead to also error. And this could be increased by the fact that processed EEG has become and is becoming even more and more popular, and there are a lot of devices out there. So we sent an invitation to experts regarding the field of EEG monitoring of various fields, experts and also non-experts. 25 of those who've been initially invited, 21 have answered. That's a 84% participation rate. And we went through the literature regarding processed EEG monitoring within the intensive care unit. And we also did our homework. We looked at the grading of we also graded these papers and the literature. And the consensus was started with the objective of the objective was to reduce the heterogeneity of different opinions regarding the use of the processed EEG within the intensive care unit. And we've done this through modified Delphi process consisting of 3 separate rounds. 89 statements were formulated, and the experts were asked to rate the statements from a 1 to 9 scale. 1 was they're completely inappropriate statements through 9 completely appropriate statements. From these statements, 28 recommendations pertaining to 4 specific domains were created. And briefly going through the various, the 4 domains, patient selection, which patients to be monitored with the processed EEG in intensive care unit. Domain regarding technology for EEG monitoring, focusing on the technical aspects, specifically various channels from the BIS, from DSA, PSI, and whatnot. The use of EEG monitors and how to use processed EEG monitoring within the intensive care unit. We also looked at the artifact identification, and the interaction between various drugs and the raw EEG pertaining to the processed EEG. We also looked at the competency to use and teach the principles of processed EEG monitoring, which is very important to continue. And like I said, I cannot get into the specifically into certain aspects, and this will save us a lot of time, but I will show you what some of the highly appropriate and statements and strong recommendations are. Regarding patient selections, they're quite upfront. There is a high agreement and a strong recommendation regarding the fact that all patients receiving sedation in the ICU should be monitored with a depth of sedation monitoring. And that has been properly presented by, previously by Stefano Romagnoli. And any patient for whom deep sedation, meaning a RASS from -3 or less, is required, they will most likely benefit from depth of sedation monitoring. And also, the depth of sedation monitoring should be used continuously, starting from as soon as possible after ICU admission, whenever obviously indicated. Regarding the technical aspects, well, process continuous quantitative EEG is adequate. There's a consensus, high agreement, and strong recommendation to, it is adequate to monitor a level of sedation. And we know that there are many technical aspects which have to be looked at, including the fact that, clinical actually, that burst suppression should be avoided in all circumstances unless it is used to, for a specific clinical condition, this, for example, to control intracranial hypertension. But when present, we all agreed to the fact that it should not be exaggerated. It should be kept below a 5% suppression ratio. And the assessment of sedation, obviously, when processed EEG values obviously can vary between patients at the same subject level of sedation, so they have to be continuously evaluated and reevaluated. When clinical scales are used, RASS and SAS, they cannot be used singularly, but in the adult ICU population, especially when using neuromuscular blockade, processed EEG monitoring becomes even more important. So just to conclude rapidly, from this consensus, important information, which is not taken for granted, is coming out and hopefully will be published shortly, that the intensivist should acquire the knowledge and competence to titrate sedative drugs in order to avoid over and under sedation. The quality of the utility of new technologies is directly determined by knowledge pathophysiology of the signals they are based upon. And we know that all this information needs to be derived from teaching, from competency, and the question actually is who will have this competency? Should it be the universities? Should it be meetings like this one? Or should it be training courses like, for example, we perform a training course every year, well, except for last year, where within the multimodality modules, we also perform training on how to use, how to implement processed EEG within the intensive care environment. And I have to say that it's fantastic to see how many also young doctors and residents are very interested, and they certainly understand the importance of such a type of monitoring system. And I thank you very much for your attention.
Thank you very much. Are there any questions from the auditory?
May I ask a short and probably stupid question? From a technical point of view, which types of sensor do you promote on routine in the ICU for standard EEG?
Well, we use the various stickers that are at hand. There are available, like 4 sensor sticker would be appropriate, obviously depending on the type of device we're using. It's very important to see the raw EEG. So I think the raw EEG, as Stefano has mentioned previously, is subject to less artifacts than a single number itself. And we could also have a quantitative evaluation of the depth of sedation, not only a number, yes, no, but also at what level and how the brain is acting. Obviously, we have to, with more numbers, we have more factors which have to be taken into consideration. Certain EEG patterns may be the same as brain damage. For example, delta wave can either be a patient who is deeply sedated, or the patient may have a brain damage. So we have to have, that's where the knowledge and skills come across. So I would say a 4-channel sensor.
No need for some OOCs, just for patients. For some patients, some OOCs and...
There are obviously the devices with more channels, and but we're moving towards a more non-invasive strategy where you have helmets and Wi-Fi, and there are a lot of devices out there which are being developed. It's incredible how the technology is just moving quickly, even without hooks or similars.
Thank you for your talk. I was wondering if at higher levels of arousal, say a RAS of -2 or higher, do you think it's feasible that either trained experts or maybe even less trained experts will be able to distinguish the difference between simply a change in level of arousal and the presence of encephalopathy or delirium? Will there be that kind of signal differentiation so that we might even be able to not only be monitoring level of sedation that's appropriate for care, but then think about whether or not there's a delirial process to be watching out for and monitoring? I wonder how possible it looks at this stage with a processed EEG. Thanks.
That's an awesome question. That's a very good question. I think if we look at it a bit beforehand, regarding the association between EEG and delirium, there's a lot of information starting to come out regarding if you see that pattern and the patient is sedated, you most likely will have a patient who will be at risk of developing delirium. Regarding a patient who has delirium, we've diagnosed delirium through various scales, and the correlation with the present EEG pattern. I'm not aware of a lot of information regarding that. Hopefully, one day this will be a lot clearer, but definitely agree upon the fact that training is a continuous process, and once that information comes out, obviously it will be a fundamental process. Thank you very much.
Thank you. So let's move to the next talk with Victor McCready from Toronto, Canada, about the sedation in practices in neurological patients.
Thank you very much for the introduction. So I'm from the University of Toronto, and I'd like to thank the organizers for inviting me to talk about sedation practices, specifically in the neurological patient. I have no relevant conflicts of interest for this presentation. And so today we're going to go through the general or the specific indications for sedation in acute brain injury patients in the neurocritical care environment, and how we do sedation vacations, or more appropriately termed neurological wake-up tests, and then talk a little bit about the agents we might use, why we might use them, and the protocolization of sedation in neurocritical care. So the indications for sedation, well, in the general ICU, we might use it for control of anxiety, help with pain and discomfort, agitation, and help with vent dysynchrony. But if we look at specifically the neurocritical care environment, we use it in a very specific way, in a more of a treatment-based, to help reduce the cerebral metabolic demand, thus helping, hopefully, to reduce ICP, as well as help with seizure control. And then finally, I suppose that more appropriately is to aim for normothermia. And so within neurocritical care, we're more specifically using sedation as a neuroprotective strategy. And so how it might help with their ICP, there's a number of ways posited that might help. One is helping to suppress the cough and Valsalva to avoid increases in our intrathoracic pressure, to reduce any backflow into our jugular venous outflow, and thus hopefully helping ICP. Other is try to treat seizures, reducing our oxygen delivery and metabolism mismatch. Then next one is to reduce pain and agitation, more specifically to try and reduce any surges in our blood pressure, which may, if you're a cerebral dysautoregulation and your pressure passive, may increase your cerebral blood volume, thus increasing your ICP. We also may use it to help facilitate mechanical ventilation, but more specifically to keep tight CO2 controls, more so to avoid vasodilatation and again increasing the cerebral blood volume. And then finally, the one that we all think about is to decrease the cerebral metabolic rate of oxygen, thus reducing cerebral blood volume and blood flow, and hopefully decreasing ICP. But even within the neuro ICU, we're sometimes at competing interests, so we might think of a deeper sedation protocol to help with ICP control, to reduce shivering and associated systemic metabolic demands. We might also think about trying to address agitation, vent dysynchrony, also for brain tissue oxygenation and to avoid any dips in PO2, as well as avoid any blood pressure variability, and then to help prevent or suppress seizures. But there's also an argument to say that we might like a lighter sedation strategy to try and minimize any confounding in our neurological exam, to help us do frequent neurological checks to try and detect critical neuro worsening, and to minimize any associated side effects such as hypotension with sedation boluses, more importantly with propofol, the avoidance of delirium, and really delays in trying to wean our patients and get them mobilized. So this deeper sedation strategy really can obscure our neurological exam, which really is our first neuromonitoring, right? Our first is a clinical exam. But some reasons why we might want to do that is very nicely outlined by Marcus Skoglund and Raymond Hellbach in a couple of single-center studies where they showed consistently that neurological wake-up tests can cause a stress reaction by increasing the blood pressure, rises in ICP, increases in stress hormone, and differential effects of brain tissue oxygenation and cerebral microdialysis. But overall, when we look through these studies, we're going to find about a third of them we can't wake up. We're going to find about another third we have to abort because of instability. And then those that we do wake up, we see an increase in their conscious level. But it does leave a number of unanswered questions about sedation vacations or neurological wake-up tests in this patient population. So does the risk justify doing it? What about this secondary stress response, and does it actually impact long-term outcomes? And in this era of multimodal monitoring, is it really necessary to subject them to that potential stress response? So patients I don't wake up or do sedation vacations is patients in intracranial hypertension, patients that I'm aiming for normothermia or hyperthermic, status epilepticus, and patients who have ARDS. This is a really nice paper by Oppendenacker, and senior author was Gert Mayfreud, and it's a review of all the sedation agents that we might think about. They've nicely outlined here the different cerebral physiological effects, and you'll see in the slide there, I don't know if I can, with that, or their barbiturates that really have a bigger effect on our ICP, blood flow, and cerebral blood flow, as well as propofol having a bigger effect on cerebral blood flow, volume, and ICP, versus things like ketamine, which we're seeing more use of. So looking at actual studies, what is the evidence? So here's a systematic review by Roberts and colleagues, but it's getting old, it's about 10 years old now, and they find about 13 RCTs, overall about 380 patients, but moderate risk of bias, and most studies enrolled a small number of patients. And when I looked through this, here to summarize for you, there was about 3 studies comparing propofol versus midazolam with no difference. Then there was another 2 studies looking at ketamine and sulfentanyl, again, no difference. And then finally, there was 1 study looking at propofol versus just morphine. And again, no overall difference, but showed a decrease in the ICP with propofol versus morphine. And so they concluded in the end, there's no convincing evidence for one sedative agent is more efficacious than another in the neurocritical care environment. Looking at how we protocolize, this one was propofol versus analgesic sedation regime, and looking in the cardiac arrest by Paul and colleagues, and it's a cohort study where they looked at before and after. They moved from midaz fentanyl onto a propofol remifentanil mix. And then looking at this, looking at the period before, then moving into the period afterwards, they were looking at time to awakening. And so overall, 60% here would waken up. So this line and above is everyone who were in a coma and then woke up. And I've just outlined here the time to awakening in orange. And you can see there's a significant longer time to awakening in the Midaz fentanyl group versus the Propofol remifentanil. And then just indicating their last time to awakening was 12 days in the Midaz and 5 days in the Propofol. But overall, they find that there was no difference in longer-term survival or favorable neurological outcome. But they did wake up quicker, they had more ventilator-free days, and they had less catecholamine-free days. Looking more, this is from a nursing group, Egerod and colleagues, where they looked at how they protocolize giving sedation just in neurointensive care patients, and it was 215 patients, a before and after design. And they moved from a sedation-based protocol onto a more analogous sedation protocol. And looking at before and after, they could see that when they protocolized it this way, they used less sedation overall when they were using more opioids. Patients that they did select to wake up woke up quicker, and they were using a pain scale. They found that those that were on the newer regime of analogous sedation had less pain. And then overall, though, the increased use of opioids. So we wanted to understand how we're actually doing it, and we surveyed through the ISICEM and the Neurocritical Care Society. And this is just one of the vignettes. We used two main vignettes. One was with intracranial hypertension, severe TBI, and the other was without. And we had 340 responses. And we asked patients, would you sedate that patient? So young lady coming in, TBI, raised ICP for longer than 30 minutes. And overall, said about 96% said they would. And then we asked them, why would you sedate them? And the majority said to drop their CMRL2, but some actually said, we just asked for their best response, was that this was actually just their standard protocol within their center. Then we asked, which agent would you use? And we can see overall that most people would use Propofol as their first-line agent. But I thought interestingly was, and now that dexmedetomidine is jumping up there, and we're finding that it was a third used agent the most often. Then we asked them, why do you primarily use Propofol? To those that had indicated that as their top choice. And we find that overall, it was really more institutional-based culture where it was recommended by their institution. And then second below that was because of that it seemed the most effective agent for TBI. We also asked about analgesia, and we could see that fentanyl was the top choice there, followed by remifentanil. And then finally, just to add in from the prior two talks, we asked them, how would you target sedation? And most people in this scenario would use ICP and brain metabolic parameters. But third down, you can see that there was a percentage there, 10%, that would use raw or processed EEG. And so I believe that we move from using a sedation scale to thinking more about, in neurocritical care, titrating our sedation to a specific target. So in ICP treatment, you might target to ICP, or we talked before maybe about a certain processed EEG. In status epilepticus, we in our institution use a sub-hairline montage 4 channels, and we either use a suppression ratio or spectral edge frequency. And then there's other things like targeted temperature management. You can use the shiver score as well as EEG or BIS. And then they're actually, once they get further out, our TBI patients, there's a parasympathetic, paroxysmal sympathetic hyperactivity scale that you can also use. So in summary, I would say that our main use of sedation in neurocritical care is quite different from general critical care. We use it mainly for neuroprotection. Think about when you're using sedation in this cohort, about trying to have specific therapeutic goals and monitor for side effects. And then I think you really have to individualize and consider the balance between sedation vacations and the potential stress response versus having an insight to their cortical function and neurological exam. So I'd like to thank you there, and if there's any questions, thank you.
So thanks a lot for this comprehensive talk. Any question in the audience? So we'll just begin with one short. Do you have any thoughts about the use of inhaled sedation in these patients? at least for cardiac arrest.
Oh, sorry, say that again. What kind of sedation?
Inhaled sedation.
What type to use?
Yeah.
Yeah, so one of those studies there was actually with the Parisian post-cardiac arrest, where they were actually looking at a specific use of either a more longer acting versus shorter acting. Do I tailor it to specific ABI, whether it's subarach, ICH, and TBI, or cardiac arrest? Overall, I would say that I use a short-acting agent, and I predominantly use more sedation than analgesic sedation. And my number one choice would be Propofol, but then taking into consideration the hemodynamics. And I think we've learned a lot from the stroke literature and EVT about blood pressure variability, and so I do get concerned about the risk profile of that and sometimes individualize the choice.
Any other questions?
Thank you very much.
Thank you very much. So we just heard of the dominant role of Propofol as a sedative agent in ICU therapy. And so Arturo Von Sumten is the next speaker, and he's going to talk about the outcome that is related to the use of Propofol.
Thank you very much. It's a great pleasure to be here live at this 40th ISICEM meeting. I want to congratulate Jean-Louis with this achievement. I will talk about Propofol from a more metabolic perspective in this session about sedatives. Here you see my disclosures. I'm not involved in companies with sedations. So I will discuss a little bit about Propofol as a sedative, and then we'll tell you a little bit about that it's parenteral nutrition, and it provides energy, and it has mitochondrial effects. And by doing this, does this lead to differences in outcome? So does prolonged administration of Propofol have adverse effects? So as you all know, Propofol is currently available in several concentrations, 1 or 2%. It's based on or dissolved in a 10% soybean oil with some stabilizers, emulsifiers, and other components. It comes with a caloric value of 1.1 kcal per ml. So just to consider, when you give like 15 ml per hour, that's very low. In surgical procedures, it goes up to much higher rates, but a little bit of Propofol, 50 ml per hour, already provides 400 kcals per day. So there is some risk of overfeeding here. And we tested that a few years ago in the study looking at the so-called non-nutritional calories. And you use glucose, dextrose, or Propofol, and also maybe trisodium citrate as an anticoagulant during continuous renal replacement therapy. And those drugs or fluids provide you additional calories. So in general, in the total population of the ICU, well, the contribution to the total caloric value is about 7 to 10%. But in individual patients on renal replacement therapy with citrate and Propofol sedation, it can be maybe 30–40% of the total calories. And it's important because we know when the total caloric intake of ICU patients is 10% more than what we measure by indirect calorimetry, so the resting energy expenditure, we see already increased risk of mortality. So you have to take care of the calories from Propofol and reduce your nutrition intake. And then it's important when you reduce your feeding, you also will reduce the protein intake. And that's very important for our patient, for recovery and long-term consequences. So then you have to maybe add proteins or use very high protein to energy ratio feeds. Now, what's in the guidelines, not the sedation guidelines, but the feeding guidelines about this kind of drugs? For intravenous lipids, it's stated in the Aspen guidelines from 2019 that the intake should not exceed 1.5 grams of lipids per kg per day and should be adapted to individual tolerance. So if you take just a patient of 80 kilograms, it's 120 grams per day, and you're only allowed to give 3.1 ml per hour. So I think you typically will give a lot more than that, but this is in the nutrition guidelines. But maybe we do not consider Propofol to be nutrition, but I think it is. So what is in the American guidelines, the Aspen guidelines from 2016? We suggest withholding or limiting soy-based intravenous fat emulsions, and Propofol is based on fat from soybeans. So during the first week following initiation of parenteral nutrition, it's recommended to use a maximum of 100 grams per week. You can divide this in 2 doses to prevent essential fatty acid deficiency. And that's about, if you calculate this, 4 ml per hour for 24 hours. So that's only a small amount that you can provide for this reason. Now let's move to the mitochondria. As you all know, mitochondria are essential for cell survival and are the producers of ATP, the energy of the cells. And during critical illness, mitochondrial function changes. And we will discuss this on Thursday in a session on mitochondria. But when there is lack of oxygen, when you have oxygen radicals, we see in critical illness that the mitochondrial respiration, so the oxidative phosphorylation, the ATP production is, well, declining. We see mitochondrial dysfunction. And we know when we look at the skeletal muscles of ICU patients during ICU-acquired weakness that the ATP content of cells is much lower. So there is a problem with energy in the cells, and it has to do with the functioning of the so-called electron chain complexes in the mitochondria. And we also know that the same occurs in the nerves of the patients during ICU-acquired weakness. So preserving mitochondrial function could be a target to prevent or maybe solve the problem of ICU-acquired weakness. And here comes the problem, because Propofol affects mitochondrial function. And in this paper, it's known that in sedated patients, it has been seen that the fatty acid oxidation or the beta oxidation of free fatty acids can be disturbed by the administration of Propofol. So from a metabolic perspective, I'm a little bit against the use of Propofol, but it's so nice to use, and it's a short-acting drug, so it's very helpful to use in the ICU. And this is work from Paul Wischmeyer, showing that normally when you do cardiopulmonary exercise physiology, so you exercise, your heart rate goes up, and at a certain moment your lactate levels will increase. You will burn glucose, carbohydrates, but also you burn some fat, but to a certain extent, and then this effect will drop. But what we see in patients with burns, but also in other ICU patients, this fat oxidation is completely gone. So some people say that fat in critical illness is maybe inert. It doesn't lead to any metabolic activity. Now, this is a very simple depiction of the mitochondria, and I will lead you through it. So we look at the mitochondrial inner membrane. This is in any living cell, and they have mitochondria. And you see we have 4 electron chain complexes, number 1 and 4, who push out the protons to the outside. And then the protons come back through complex 5, and that's the system to produce ATP. And you see there are many cofactors that are vitamins and trace elements involved in optimal functioning of the mitochondria. And you see also that there's this line from carnitine down, and we need some enzymes, the carnityl acyl transferases, to get the free fatty acids into the mitochondria and to have them metabolized into acetyl-CoA. And as you know, acetyl-CoA is the start of the citric acid cycle to produce ATP. So when you have carnitine deficiency, the system does not work very well. So recently we encountered 2 patients with COVID-19, among many others, of course, but we found during propofol sedation in the ICU that they had high levels of triglycerides. So one patient had levels of 12, another 8, and we get a little bit nervous when it goes over 3 millimoles per liter in our ICU. So it was high levels of triglycerides. Of course, we stopped the propofol infusion in this, but what was important to notice that this was a mother and a son. They were both infected with COVID-19, and we measured carnitine levels, and we saw that the total carnitine levels were high, so there was no carnitine deficiency, but they had a high carnitine to acylcarnitine ratio, and the acylcarnitine should be produced to help this beta oxidation in the mitochondria. So this is how it works. To get the free fatty acids in, you need carnitine, you need this, this active form, the acylcarnitines, to do the job, and you need enzyme for this. The enzyme is the carnitine palmitoyl transferase, or CPT1. And there are inborn errors of metabolism having this problem in children, but it was not known in this family. So we measured this again in these 2 patients after being discharged from the hospital, and then it had completely normalized. So there was no inborn error, because it was a family. We thought maybe this is an inborn error of metabolism, but it was due to the effect of propofol. So propofol can affect this free fatty acid metabolism. It has also been shown in the propofol hyperinfusion syndrome, leading to multiple organ dysfunction syndrome, as you all know. So then we thought about maybe we can study this in a more case control-wise manner by comparing patients who were treated with propofol in the ICU versus other, well, sedation regimens. And my assumption was that the propofol patients would do worse because it affects mitochondrial function. Mitochondrial function is associated with outcome, so it must be bad for the patient. So we did a retrospective comparative study in over 450 patients, and here you see the baseline characteristics, and on baseline, due to selection, probably physicians select other patients for propofol use than no propofol use, and you can imagine this. First of all, it's striking to see that 80% of the patients at any moment during ICU stay used propofol. And you see a significant difference in age. So propofol patients were younger, and the Charlson comorbidity index was slightly lower, but it was significant, and we saw less medical patients treated with propofol, and there are also slight differences in other admission categories here. And then we thought about how to see what is the effect of mitochondria when you don't measure the mitochondria, because it's very complex to do. So we thought about, in the end, if ICU-acquired weakness is more common, it should lead to a different discharge disposition of the patients. So it's difficult to see here. Either they're going to a rehab clinic, a nursing home, or there is in-hospital death. So we made a composite endpoint. And for the composite outcome, you can see that use of propofol during ICU stay had an odds ratio for 6-month mortality of 0.5. So it was beneficial. And of course, this was adjusted for SOFA scores, Apache 2 scores, and all kind of other covariates. And you see, if you only take 6-month mortality, it's does not associate with a negative effect on mortality. But we found it very surprising to see this, because it seems that propofol is rather safe and it doesn't lead to long-term consequences, although there could be some effect on mitochondrial function. So we're working on the data and we hope to publish it soon in its final report. But what I'd like to conclude with is that I've shown you that propofol is a lipid emulsion. There is a risk of overfeeding. You have to take these calories into account and adjust your feeding intake for the intake of propofol. There is a risk of fat overloading, so I think you have to check your triglycerides on a regular basis. It may affect the beta oxidation of mitochondria, and it may induce mitochondrial dysfunction. But in our study, this did not lead to negative long-term outcomes effects. So we are speculating now, it could also be a reverse hypothesis, because in many patients, mitochondrial function goes down, and maybe this is an adaptive process, but when the functioning of mitochondria doesn't, well, resume after some time, we see long-term consequences and increased mortality. So could it be that propofol helps to bioenergetically shut down the mitochondria in the early phase of critical illness, and then you stop the propofol, and maybe it helps to restore the mitochondrial function? Of course, this has to be tested in new prospective studies, but for us it was very surprising to see this, well, opposite effect to the hypothesis of propofol effects on mitochondrial function. With that, I'd like to conclude and thank you for your attention.
Thank you very much. Any questions?
What is the triglyceride level you use to stop the propofol infusion? What is the maximum point?
The maximum, we use 3 millimoles per liter already, because, well, there are some data, but it's from other areas like parenteral nutrition, and so that if you have prolonged levels above that level, that it can lead to hepatic steatosis and other consequences.
So at 3.0 you stop
propofol, we
completely?
try to use another sedation regimen to...
You exchange or you just reduce the dose?
We try to reduce, but sometimes the dose is not even so very high. As I showed you that in the guidelines, maybe 1 to 4 ml per hour is already high from a metabolic perspective, but for sedation, that's a rather low dose. So in many patients, you have to completely stop it then. And in most patients, then we see that it normalizes also. Yeah.
Thank you.
I have also a question. So I think it's pretty interesting, and I'm very thankful for these results. And I'm wondering whether this is in accordance with the concept, for instance, suggested by Marvin Singer, that cell shutdown is beneficial in certain circumstances and kind of the adaptive response to stressful situations.
Yeah, I know he has this concept of the flat batteries, and that, well, it could be. We know, for instance, that studies with thyroid hormone and growth hormone to boost up energy and so on, to have anabolic effects, have negative effects on outcome in the early phase of critical illness. So maybe later these effects disappear over time when inflammation resolves, and then we can give more nutrition, we can maybe give anabolic hormones and so on. But it's just a matter of timing, and we want to do it in the early phase, and that's maybe difficult
Are
for the
there any
patient.
options to determine whether we are in the early phase?
Yeah, we're working on that. We have a list of biomarkers and try to find out what is the moment of the switch from a more catabolic to a more anabolic state. But I think that's a $1 million question to answer.
Andreas, last question.
Hello, thank you for this interesting talk. I'm still astonished by your conclusion that the odds ratio was in favor of propofol. Well, mitochondria are certainly very important, but there are also other important things.
Yes.
You compared propofol to other intravenous drugs. So we know that sedation is bad for the patient. We know that deep sedation is bad for the patient. We also know that even very early deep sedation is bad for the patient. So could it be that propofol is bad, but not as bad as other drugs.
I totally agree. And maybe, as was already alluded to by previous speakers, that maybe the duration of sedation and the wake-up time was better using the propofol. So, of course, there are other aspects involved, but we wanted just to look at it because it's not in the literature, although we couldn't find it. But we were interested in the long-term consequences because most studies focus on ICU or in-hospital mortality, and we were more interested in the long-term consequences of this effect.
Okay, so let's start the next presentation about ketamine use. Thank you.
Thank you. So I'm excited to be here today to talk to you about a drug and a topic that you will see I feel very passionately about for many reasons, both in the care of my patients and in providing their comfort through procedures perhaps you'd never think to sedate through, but also as an alternative sedative in COVID-19 where propofol, as we've heard, may not always be an option due to hypertriglyceridemia. And ketamine has got many, many new uses for asthma, for many different diseases, seizures, and perhaps as a COVID-19 sole sedative. So the first time I really got to know ketamine was when I was an anesthesia registrar. And I was called as a very young first-year anesthesia registrar to take care of a child in the CT radiology suite. And I will tell you that whenever I ask my attendings about ketamine, this is what they always said to me, is that I would cause bad dreams and cause nightmares, and I must be a barbarian. But I learned a lot about it when I was called to take care of Madeline. She was an 18-month-old who had a lung abscess. And the pediatric resident called me down to radiology just in case so I could watch and stand by. And you can see the child has a significant lung abscess that was communicating with the bronchus of the lung. And the child was slowly but surely becoming septic, although at this point was quite alert and active. So we get ready to get into the CT scanner, and the child strapped down to a board, and can you imagine, is not happy, is angry and crying. Mother's watching outside through the clear plastic window. The radiology attending is going to put a drain in this abscess, and he says to me, could you suspend respirations and hold that kid still? And I said, that's more than just watching. So I called my attending, and I talked through him what we might do, and we needed brief, deep sedation for this child. We needed good hemodynamics, and we needed spontaneous breathing because, let me go back, we needed spontaneous breathing because we wanted to avoid positive pressure ventilation because we might burst this abscess. And so the drug that came to mind that was perfect was ketamine. Now, of course, his look to me was, oh God, the kid will wake up and have nightmares. We'll use propofol, it'll be so much safer, it'll be so much better. So he proceeds to push a large dose of propofol to this child. The child goes apneic, as you might guess what happened. And he has to initiate bag mask ventilation pressure in this patient. Moments later, unfortunately, copious pus begins to pour from the oropharynx, and the SATs begin to fall. And the SAT probe is dropping beep, beep, beep. You've all heard this, unfortunately, before. They go to look to intubate, and there's a mouthful of pus. They can't see anything. Remember, this is an 18-month-old. You don't have long once they get hypoxic. Unfortunately, moments later, the child's SATs drop off, and his heart rate begins to fall. And minutes later, Madeline's declared dead. She died because they couldn't intubate her. She became hypoxic. Could ketamine have made a difference in this child in this sedation? Let me tell you about another patient I took care of not so many years later as a young attending in anesthesia. I also practiced in anesthesia. This was a young man named Michael who was a 16-year-old with Downs. He weighed about 140 kilos, and he loved martial arts movies. He was coming for a dental extraction, and he told me that if I stuck him with an IV, he'd had these before, that he would knock me out, and he might have. So the goals for this child, right, are to get him back to the operating room with an oral medication, because you're not going to get a needle near him. It has to work fast. It has to be good pre-procedural sedative. And with his airway, you need to keep him breathing. Ketamine. So I mixed up some ketamine and some cherry syrup with some midaz and some glyco. And moments later, he's asleep. He has an IV in. He's cooperative. He's breathing. And he goes back to the OR. So success. And no one got hurt, which was a plus. So with ketamine, of course, patients have always been said they could have nightmares. But to start with, I might advocate you, like with Madeline, you have to wake up to have nightmares. And so there's a lot of things we do where sometimes this is the safest drug we'll use. And there are a lot of other things you could be using ketamine for that are not just safe, but are beneficial to your patient. Is this the best drug perhaps you've never tried? Well, what is ketamine? And how many of you use ketamine regularly in your ICU? Raise your hand. I like to see that. It's a lot different than 5 years ago when I gave this lecture, and only about 15 of you raised your hand, so we've come a long way. Of course, we know it's a dissociative anesthetic. I won't spend a lot of time on its prelude, since most of you know how to use it. It's wonderful because it gives you amnesia, it gives you analgesia, maintains respiratory drive and hemodynamics. And its limits of use have always been, oh, it causes nightmares or emergence delirium, which I can tell you is treatable. But most of us don't get taught how to treat it. Well, can we be smarter? And there are many new roles for ketamine. There was just a brilliant review in Critical Care Medicine, you're going to see this paper again that came up, that talks about all the new uses of ketamine. If you want to take a picture of this paper again, you'll get to see it one more time, of course. So how does ketamine work, or what is it? Of course, it's a phencyclidine derivative. It's a racemic mixture of two isomers, an S isomer that has a greater sedative effect, fewer side effects, perhaps, better recovery time, and an R isomer. I know in Europe some places have both isomers, and this is better for bronchodilation, like in asthma. So there's a lot of interesting things about this drug. It's an NMDA receptor agonist. It's unique amongst many of the drugs we use. At low doses, it's all NMDA, and at high doses, it begins to bind mu receptors and sigma receptors, and the loss of consciousness appears to be due to that effect. So interestingly, of course, it may prevent long-term pain in patients who get it early, prevents wind-up and pain memory, may reduce pain long-term postoperatively, we love it in anesthesia, works through a number of different pathways to do this, and it seems to reduce opiate tolerance. So dosing, of course, there's a lot of ways you can give ketamine, IV, IM, PO, intranasal. I've given it all these different ways. They all work. For intubation, the dose is larger than for sedation, obviously. And this is a drug you always want to give some glycopyrrolate with to prevent secretions and hypersalivation. But how do we stop the nightmares? So, of course, the key to success in using this drug that I teach my registrars is you always give 1 to 2 of midazolam, 1 dose, at the beginning. And the most important thing you can do is you need to give a dose 30 minutes after the last dose of ketamine. It's the most important thing I'm going to say to you about preventing the nightmares we all hear about. And I will show you from personal experience you can do that. So again, this has to be at every 30 minutes throughout your use, and then at the end, 30 minutes after. Okay? Onset of action is very quick, no matter how you get it, except for intranasally, it's slow. Its peak effect is very fast. Its half-life is short. Its real action life is 20 to 30 minutes, I will tell you, in a patient. And intranasally, it lasts much longer. It's hepatically cleared, so you don't need to adjust anything in renal failure. Organ-specific effects, it increases heart rate, blood pressure, and cardiac output by release indirectly of catecholamines. So if you're in heart failure or if you're in prolonged shock, it's not going to do that for you. It will work like any other sedative. So in these very extreme long-term heart failure patients, you can have pressure drops and other things, but you give it to a young person, their pressure and heart rate's going to shoot up. You might want to have some labetalol or metoprolol handy. Maintains respiratory drive. I found at just about any dose. Some people have seen some small respiratory depression, but I've seen almost none, and using it now for 25 years. And it increases pulmonary pressure, so pulmonary hypertension is something to watch. And it's very potent at reducing bronchospasm and asthma, which we'll get to. For those of you in the GI tract, and I didn't learn this until just a few months ago, it improves gastrointestinal motility. It probably facilitates feeding. May lead to better feeding versus, say, opiates. And it actually reduces free fatty acids. You heard how propofol is skyrocketing free fatty acids in COVID patients. This actually reduces them, so that's fascinating. I didn't know that until I did some more reading. Reduces uterine tone, and it's anti-inflammatory, some recent research has shown as well, which is interesting. What about the current literature and the new uses for this drug? So obviously we all know it can be used as an adjunct analgesic. This is the Cochrane review from a number of years ago. Again, it doses 10 to 35 mics per hour. Sorry about that. You can use this drug as an adjunct to your PCAs and to your IV opiates. It's very effective at reducing all the things we want an adjunct drug to do. Reduces the amount they need, reduces some of the side effects, has a lot of good effects in that setting. Again, perioperatively we use this a lot too prior to induction of anesthesia. It's very useful for adjuncts of spinal and epidural anesthesia, and these are the doses we typically use. Traumatic brain injury was an area we avoided it, but recent research has shown us that's probably not something we need to do. A review of all the data that existed in 2005 showed that ketamine does not increase ICP if you're controlling respiration and ventilation. The medical student studies where they just gave people this drug and didn't control ventilation, yes, you have some CO2 rise, some increase in ICP. Does not do it under controlled ventilation settings. Also is directly neuroprotective, some studies in the laboratory will tell us. It's a nice summary of how to use it in this paper. Again, these are the doses. Use it early. It's good in status epilepticus. It seems to affect seizures through calcium influx. So again, this is a new treatment for severe status and refractory status. In pediatrics, it's better for sedation than just about any other drug you can give. I would suggest using it for pediatric procedures. It's better than opiates, Midaz, Propofol. It's much better for kids. Rapid sequence intubation, I intubate almost all my patients in the ICU with this drug because it's the only time my residents registrars see it. It's the only drug that increases cardiac output, heart rate, and blood pressure of all the sedative drugs you can give. So it's really good at maintaining the blood pressure and looking like you know what you're doing when you're putting a person to sleep and not having to push a lot of neosynephrine after you do the intubation. Randomized trials agree with this. It's better and safer than etomidate. It led to a trend towards decrease in mortality and lower SOFA scores when used versus etomidate in high-risk hemodynamically unstable patients. And of course, it doesn't cause adrenal suppression like etomidate does. So this is a benefit. So this is a benefit for intubation. I use it all the time. What about asthma? It's a bronchodilator. It's very potent. I have rescued people. I don't know if Ivor Douglas is in the audience. I know he's here today. He and I took care of a patient once at the University of Colorado, I can remember, where there was nothing else that was working. The PCO2 was 150. We started ketamine. By the next morning, I was getting ready to extubate that patient. And so there's a lot of data for this. New use, alcoholic withdrawal syndrome. I didn't know this. This was just published recently. This is a nice drug in that setting. Again, it seems to work uniquely versus the other things that we use. There was a nice publication in critical care medicine that showed in people that were getting phenobarb or benzos, giving this in addition, whether it be by bolus or just infusion, led to reduction in ICU length of stay, led to reductions in intubation needs, and reductions in the amount of midazolam that they got. So new use for this. I've actually never used it for this, but I'm going to. I've definitely used it in agitation and delirium. So ketamine is ICU sedation. So clearly we need alternative sedatives. With COVID, propofol has become an issue, and we know benzos cause cognitive dysfunction without question. So a lot of small studies that have looked at this. It has a lot of advantages, especially early, reduces bronchospasm, maintains blood pressure. You can see there's a lot of small studies with lots of big doses at varying amounts, given these are the different doses that have been used for this drug. So you can see there's a large variety of doses. I've used it at usually 1 to 3 milligrams per kilo per hour. And then it's cheaper. This is a much less expensive drug than any of the other sedative agents. And so that's an advantage as well if you're going to move to it. This was an award-winning abstract at SCCM 2 years ago, 2020, last year actually. Ketamine initiation versus the 24 hours prior to it on propofol or other sedatives. Goal pain scores were better. Goal sedation scores were better on ketamine, and there was equal delirium, not more delirium. And so it doesn't lead to increases in delirium. This was using as an adjunct and analgesia sedation. I can't even say the word, but analgesia and sedation alternative. So again, there's some nice recommendations in this paper. I use doses that are a little bigger than this. Usually I'm in the more 1 to 2 milligrams per kilo per hour range, but this is something you can do. So again, how do we stop the nightmares, maybe even literally? Ketamine treats PTSD. So this is a study that was in burn survivors in the military, and they showed that patients who received ketamine as part of their burn ICU care had about half the PTSD than patients who didn't, who would have thought that we think it causes nightmares, it actually may reduce them lifelong. And it's being used actively in primary PTSD. Patients who get single doses of ketamine have less PTSD reports when they measure them in some studies. So again, this may actually help your patients have less nightmares. So as we get towards the end here, clinical pearls, making ketamine use painless. Yes, that is actually me getting it. It's the ideal drug for many procedures. Fiber optic awake intubations, there is nothing better. Don't give any opiate with it, they'll stop breathing. You can sit somebody up, you can sit on their carina, you can have that scope in their airway for an hour, they won't move. It's ideal for teaching and doing very difficult awake intubations. Rapid sequence, burn dressings, interventional radiology. I use it for hard central lines, lots of purposes. So it's the ideal drug for lots of different things. This is an example of a child, a 2-year-old with a lac on their lip. Again, your goal here is, even though they maintain spontaneous respiration, they may not prevent aspiration. Try to have them be in PO, or if you're going to intubate them, rapid sequence them. It's not guaranteed they're going to maintain their air reflexes. So again, that's not perfect. Have your airway equipment available to you. I've never had to intubate someone purposely who I sedated with ketamine, but it could happen. They could laryngospasm, it's rare. These are the doses for procedures. I usually give 20 milligrams at a time to an adult in small intervals, like for an awake fiber optic or another procedure. Gets me what I want almost every time after I give the glyco. Midaz every half an hour, a little at the beginning, and then 30 minutes after the last dose of ketamine, midaz again. So again, you can give it orally, mix it in something. The midazolam tastes terrible. Kids, adults hate it. I use it down feeding tubes a lot for sedation in kids. Again, you can give the glyco and midaz with it. The oral midaz dose is bigger. The ketamine tastes fine, from what I'm told. The oral midaz tastes terrible, so you have to mix it in cherry syrup. So again, you can see this child actually got it IM, which is another way you can give it. On rowdy patients, twice in my career I've given it to protect nurses. Mom's holding the child. You can see the ketamine stare, sewing the lip up. Child isn't moving. Won't remember this, won't feel the pain of it. Child wakes up nicely. So takeaway points. Hemodynamic stability is the hallmark of this. Maintains the respiratory drive, analgesia and sedation. And you can give it any which way you want. Lots of routes of administration. Give glyco first, midaz following, ensure they're in PO, have your airway equipment ready. So again, these are the doses and the nice range of doses in this table from this paper. This is a nice slide to have, nice thing to take a picture of or to get this paper online. I believe it's free. This is the University of Michigan's protocol. I can send you this whole protocol if you'd like. Someone from there sent it to me. It's excellent. It shows you the nice range of doses you can use. So as we finish, there's a lot of good physiologic and data reasons to use ketamine and to think about using it, but why do I use it every day and how did I start using it and why I hope you'll use it too? Well, some of you may know when I was a kid and young, I had many, many abdominal surgeries and spent a great deal of time in the ICU myself and underwent many central lines and other procedures. When you're doing a central line, this is what you see. You know exactly what you're doing. It doesn't seem like a big deal. This is what the patient sees, and they know you've got a spike coming at their neck. They think the size of your finger, which is what I always thought, and it's terrifying. I sedate for central lines in awake patients, and this is a good drug in small doses to do it. Interventional radiology, some of the most traumatic memories of my whole life. I've been spending an IR table having drains stuck into my pelvis, and they say just 5 more minutes. How many times have you said to a patient, just 5 more minutes and we'll be done? But it takes you 3 hours. They're suffering. This would make a difference. And then, lastly, I went skiing with all my kids 3 years ago. When we were skiing at Breckenridge in the US, and I was going down the hill, and I could see from the corner of my eye an out-of-control skier flying down the mountain at my then 9-year-old. I skied out in front of him and put my arm out like this, and the skier hit me, pushed me into a snowmaking barrel, which somehow snapped my arm. I felt it break immediately. Luckily, my child was not hurt. This was my arm after the injury. I had a major arm fracture and wrist dislocation, no blood flow to the hand. My hand was totally numb. So they bring me to the ED, and they tell me they're going to relocate my hand, of course. We'll just use some lidocaine. I said, the hell you will use lidocaine? And I said, no. As I realized the person doing it, I used to work in Colorado. I had trained as a resident in the burn unit in his emergency room program. I said, my wife and I are going to talk you through ketamine. That's what we're going to do. And so we did. This was me on ketamine. This is me getting my wrist relocated. I didn't take these pictures, obviously. And this is me, listen closely, waking up. Memories, not unpleasant memories. And the world was moving very slowly, I will say. But in the end, is ketamine perhaps the best drug you've never tried? And if you try it, you might like it, and your patient might as well. And patients like this still might be with us. So we can do better for our patients, and we have an opportunity with ketamine to do a lot of things better for our patients and achieve our goals for our patients and achieve their goals as well. And with that, I'll be happy to take your questions, and please feel free to email me for any of these or follow on Twitter or Instagram for data on this as it comes out and is published. Thank you.
Any questions from the audience?
So one thing that's come up in our ICU a couple of times when we try to use ketamine as an adjunctive for pain is that we have patients who have very good pain control, but who then get stuck in the ICU because there is no way to give this in the ward. Do you have a protocol to follow that up?
We do. We do allow ketamine on our wards, and at least many of our U.S. hospitals do as well. It is a very safe drug we found to use on the ward. We keep our doses within a tight range, of course, and we have a pain service consult on all those patients. And so we actually find it's a very nice and safe drug to be used on the wards, but you do need a tight protocol that your nurses and your pain service anesthesiologists interact with you on, for sure.
Hello. Thank you for your very entertaining presentation. I love ketamine. But what about the Propofol? Why don't you mix it with Propofol?
Yeah, so
I found it much better than combination with benzos.
So as Arthur said, I don't love Propofol because it causes a couple things. One is apnea. So my goal in using ketamine, right, is to maintain spontaneous respirations. As soon as you start mixing Propofol with ketamine, you're taking away one of the main benefits of the drug, and you're likely or potentially going to cause apnea and hypotension potentially in that patient as well. So it sort of is the opposite of all the goals that ketamine brings. Ketamine maintains spontaneous respirations. Ketamine provides analgesia, provides amnesia, keeps the heart rate and blood pressure up in most patients. Propofol does the opposite of all of those goals. And tiny single doses of benzodiazepine are not going to have any long-term negative effects on your patients like infusions clearly do. Again, to me, that's the antithesis of how ketamine should be used because it's the opposition of all the other goals that Propofol brings with it.
Well, so I would suggest you should try very low dose Propofol infusion. It takes away most of the side effects that you've mentioned. But I found that mixture is perfect.
Yeah, and I know lots of ER doctors that do the same, so I know it's used widely in that setting. So, thank you.
Okay, last question from my side. To whom you wouldn't give it at all? Sure.
So, severe heart failure, severe pulmonary hypertension, people that are in uncontrolled SVT, AFib, atrial tachycardias potentially. I have given it to them, but realized it could increase the tachycardia. It's potentially clear in the hepatic realm, so there's no data on it being long-acting in hepatic failure patients, but you should be thoughtful about it in hepatic failure patients. I think that's probably the main base of patients that I would think about it. And it's those patients who have chronic catecholamine depletion. Now, that said, you have to give them some sedative if you're going to intubate them or do a procedure on them, let's say. So any of your other sedatives are going to do the same thing Propofol or ketamine would. Then they're going to drop their pressure, potentially drop the heart rate. They're going to have the same risks. So I often still choose ketamine because it still maintains spontaneous respirations. And then I have some metoprolol by hand close by or some labetalol if their heart rate becomes a problem. It's a good question.
Thanks a lot. So we are going to move on. So the next speaker is Dr. Andreas Meiser from Homburg Saar. So he's going to tell us whether inhalative sedation is hype or rather substantial improvement.
Dear colleagues, I've been asked to talk about inhaled sedation, hype or substantial improvement. These are my conflicts of interest, sorry. In the last years, I received money from Sedana Medical, Dahlhausen, and Covidian Medtronics. The reason why I was asked to talk about this subject was probably because last week we were able to publish a study in the Lancet Respiratory Medicine with the title about the study, inhaled sedation compared to Propofol, inhaled isoflurane versus Propofol for sedation of invasively ventilated patients. This was a phase 3 study, which means it was undertaken in order to get drug registration. And indeed, we have a European approval these days for isoflurane as a drug for intensive care sedation. So in the first part of my talk, I will talk about the study, and then I will show you some other studies and discuss whether inhaled sedation is a hype or an improvement. The short term for the study is SED001 because it's the first pharmaceutical study sponsored by Sedana Medical. It was a randomized controlled study comparing isoflurane versus Propofol for up to 48 hours. It's a phase 3 registrational study, and with every registrational study, you have to look at efficacy and safety. Well, actually, this is boring because we know that isoflurane is efficacious. It works in the OR, and it does also work in the ICU. And it is safe because we know it since more than 40 years now. But in order to get approval, you have to show to the authorities that this is the case. The primary endpoint was thus the time in the specified sedation range. Sedation was defined via the Richmond Agitation and Sedation Scale, and patients had to be in the range between -1 and -4. It was a non-inferiority study, a multi-center study involving 21 centers from Germany and 3 in Slovenia. And it was open label because many procedures reveal the characteristic smell of isoflurane. I think it's really hard if you try to blind such a study. And also we did not want to renounce on gas monitoring for safety reasons. This is the study overview. Patients had to be on the study drug within 48 hours after intubation, which was sometimes quite hard because we had to screen the patients and the informed consent procedure had to be done. They were randomized to isoflurane, 150, or to Propofol, 151 patients. And these drugs were titrated to the RAS target. RAS was assessed every 2 hours. The primary opioid used was sufentanil, and analgesia was assessed with the behavioral pain scale. Every day we made a spontaneous awakening trial, stopping the sedative and the opioid, and measured the time to wake up, and also reassessed the need for continued ventilation and sedation. After 48 hours, the study drugs had to be stopped, so the patient was either extubated or treated further according to the treating physician with the standard of care, or he could also choose to keep him on isoflurane, but this was outside the study. We looked at adverse events and concomitant medication for another 24 hours, and then we also looked at more data: organ function, coma, delirium, ventilator, ICU, 3 days mortality in a 7-day and in a 30-day follow-up. So the primary endpoint was met. This is the percentage of time the patients were at the prescribed RAS range. As expected, very high percentage of time they were sedated in the RAS range between -1 and -4. And the lower confidence interval, lower confidence of isoflurane is well above the pre-specified non-inferiority margin. So let me show you 3 more results. Patients during isoflurane sedation needed significantly less opioid, about 30% less. This is shown on the left y-axis, given in morphine equivalent doses. This was significant on day 1 and for the whole study period. On the right axis, you see the behavioral pain scale, which goes from 3 to a maximum of 12, and to see that all scores during the whole study were very low and similar between the groups. So, second, patients during isoflurane sedation were breathing spontaneously more often. On this diagram, this is the main study. This is the rate of spontaneous breathing on the day 1, estimated by the statistical model with repeated measurements. It was 50% in the isoflurane group and 37% in the Propofol group, and it was statistically significant. Here I show you the subgroup of our patients. We included 66 patients in our center with more detail every 5 minutes, and you can see the curves diverge. And isoflurane patients are breathing spontaneous much more often and quite early compared to Propofol patients during the first 20 hours of study sedation. Third, the time to wake up was short in both groups on day 1. There was a trend, but no difference in favor of isoflurane. But on day 2, after more prolonged sedation, we have a gap here. Patients after isoflurane wake up more quickly. And there's also less variability in the wake-up times. So you can say after prolonged sedation, wake-up is faster and more predictable after isoflurane compared to propofol. These are the safety assessments, and I skipped these. We looked at many things, adverse events, lab values, SOFA scores, ventilator-free days. There was a slight advantage in favor of isoflurane, but not significant. So we did not find any differences of note. I summarize the study. Isoflurane administered via the anesthetic conserving device was efficacious and non-inferior to propofol. Opioid requirements were lower, spontaneous breathing was more common, time to wake up was short and predictable, and isoflurane was well tolerated when given in sub-anesthetic doses for sedation in the ICU. So let's look at some more studies. This is the first study evaluating the use of the anesthetic conserving device in the ICU by Peter Sacchi, published already in 2004, quite old actually, the whole method. And they looked at 40 patients up to 96 hours sedation, comparing isoflurane with midazolam, and these are the awakening times. There's a huge difference. This is the time until the tracheal tubes are removed, extubation. This is a time until following commands. And note this y-axis is logarithmic, a huge difference in wake-up times against midazolam, of course. This same group of researchers published a small case series of 12 patients after cardiac arrest. They were treated with therapeutic hypothermia below 34 degrees. This was state of the art at the time, sedated with isoflurane. And after rewarming and after stopping the isoflurane, within 24 hours, all patients could be assessed neurologically. 6 patients had low GCS scores, and 6 patients had good GCS scores, and this was remained over the next days and weeks. And the 6 patients with poor GCS scores all died, and the others had a good outcome at 6 months. We all know that actually sedation is bad for our patients, especially deep sedation, and even early deep sedation is bad. This is one of the publications of Shehabi from Australia, a multi-center study, and deep sedation was defined, early sedation was defined as the RASS score at 4 hours after intubation, so very early. And with the RASS score, after 4 hours after intubation, he could predict mortality. So this is definitely important, and this is, at least it's true for intravenous sedation. For inhaled, we don't know. We did a study a retrospective study looking at all our patients over 6 years, all patients that were sedated and ventilated for more than 96 hours. And we found a survival benefit for the isoflurane group, even after adjusting for age, malignancy, and the SAPS-2 score. This is a famous study from Jabondon from France. They looked at sevoflurane in ARDS patients, and they could show an improved oxygenation on day 2, so after 48 hours of sevoflurane versus midazolam. They also found less cytokines and less S-RAGE. S-RAGE is a marker for alveolar epithelial injury. So maybe inhaled sedation is good for ARDS patients. This is another retrospective analysis of our group. We looked at our first 20 COVID patients with ARDS. They were deeply sedated over long time periods. We looked at more than 300 sedation days. And we found that whenever isoflurane was used, there were less neuromuscular blocking agents used. There were less additional sedatives used, like benzodiazepines or clonidine or ketamine, and opioid dose was also, again, decreased. So isoflurane seems to be as valuable as a sole sedative in these patients that need deep sedation. So what about spontaneous breathing? Is spontaneous breathing possible in patients with ARDS and with deep sedation and when you do prone positioning? The answer is yes. This is a study from Haider, from Freiburg. They looked at 62 patients. This was a prospective study. Patients were deeply sedated with inhaled sevoflurane, and they were able to breathe spontaneously during most of the time. These are the hours of prone positioning. Which one is better? Well, this is still a subject of debate. In my ICU, we try to do spontaneous breathing also in severe ARDS. We did not include patients with severe ARDS in the published study for several reasons. But this is much debated, and some experts still, they say that in severe ARDS, for the first 48 hours, patients should not breathe spontaneously and should be on continuous muscle relaxation. So I think we will have quite a debate tomorrow in the ARDS section. So if you are interested, please come. This is just one. In organ donors ventilated for as little as 18 to 69 hours, they found profound muscle atrophy. So I summarize, inhaled sedation has some flaws. It needs special equipment and training of staff. Patients must have tidal volumes above 200 milliliters because also the small device has a dead space of 50 milliliters. It can only be used with invasive ventilation, and there is a rare risk of malignant hypothermia in those patients that are susceptible to it. These are the strong points of inhaled sedation. It allows short, predictable awakening, even after prolonged administration in elderly patients and patients with renal and hepatic failure. It allows early and reliable neurological assessment. It allows a monitored titratable deep sedation, for instance, in status epilepticus. It allows a reduction in opioid dose with less intestinal paralysis, possibly less delirium. Studies are underway. It is a bronchodilator. Maybe it's good in ARDS. It allows early spontaneous breathing. And it can be used in COVID patients as a sole sedative. My last slide. Please use inhaled sedation only if sedation is really indicated. If you do that, I think we have a new approved therapeutic alternative and a substantial improvement for our patients. Thank you.
Any questions? I've got one. Does anybody in the audience use inhaled sedation in routine? Very few. So we use inhaled sedation in routine, and especially during the COVID-19 pandemics, it helped us just treating the patient, just sedating the patients while we were experiencing shortages in anesthetic. And we had no problem, but we use it for more than 15 years now in routine.
Thank you.
Another question from my side. How do you sedate RDS patients when you are proning them? So how deep?
We would also use the LCD. And in most cases, as Haider has published, it is possible to let them breathe in prone positioning and deep sedation, breathe spontaneously, with high peeps, of course. Okay, thank you.
So let's move to the next talk about the concept of lung protective sedation.
Thank you all for having me here today. Thank you. This is really exciting to be talking about this today with you all. So I think one of the things that I'd like to talk to you guys about today is this concept of lung protective sedation, changing the very way we think about sedation. Rather than thinking about it as a sedative scale, thinking about how we actually are trying to actually focus on the underlying lungs themselves. Here are my disclosures. So let's just start with a case. So this is a, this is a 48-year-old gentleman with COVID ARDS who's deeply sedated with a RASS score of -5. And unfortunately, the patient is actually having frequent reverse triggering with large intermittent breath stacking events as well. And here, I think you can all recognize a patient like this, right? Very deeply sedated per RASS score, but with markers that they are actually really dysynchronous with the ventilator. And I think this really kind of brings to the point of how we think about sedatives itself. Are we thinking about it per sedation level, or something more important, potentially how synchronous they are with the ventilator, or are we preventing the inherent lung injury from it? And so oftentimes I feel like we're being forced to kind of decide between two competing goals in our patients. On one side, we have the prevention of ventilator-induced lung injury and self-induced lung injury with sedation. And then on the other side, it's potentially a counterpole for diaphragm protection. They worry about prolonged intubation from sedation and all the complications that are potential with prolonged intubation, including ventilator-associated pneumonias and myopathies, et cetera. I think, though, we can really start thinking about protection of the lungs by sedation in a couple of different ways, depending on what you're focusing on. So in our sickest of sick patients, we have ventilator-induced lung injury that we're trying to prevent. And in this case, we can think of it as tolerance of uncomfortable settings, right? Lung protective settings are uncomfortable. So we can use sedation to protect the lungs through tolerance of this. As opposed to self-inflicted lung injury, this idea that patients' own breathing activities can injure the lungs, which has evolved dramatically in the last 10 years or so. In these patients, you can think of lung protective sedation as potentially removal of all of spontaneous breathing, potentially in this early phase of ARDS, but maybe actually even more importantly, reduction of injurious levels of effort. So maybe we allow spontaneous breathing, but we make sure that it's actually at safe levels for patients. Similarly, dysynchrony, I think, has gained a lot of attention for patients. Dysynchrony itself can be harmful. It's associated with poor outcomes for patients as well as direct injury. And then, of course, in these patients, we can think of lung protective sedation as the removal of the injurious dysynchrony. Not necessarily higher levels of sedation, but actually titrating to synchrony for the patient. And then lastly is this idea that the common final pathway for a lot of mechanical injury is this biotrauma, right? This is secondary to both the underlying cause of the lung injury, but also secondary to the way we ventilate our patients as well. And so in these patients, we can think of this as both the sort of reduction of the mechanical trauma from the prior effects that we talked about, and then maybe in some cases, actually direct reduction in local inflammation and direct protection of the lungs from the sedative agent itself, which I think is not typically the way we think about our sedative agents. And so in terms of sedation and synchrony, I think there's a general understanding amongst most critical care physicians that higher levels of sedation and analgesics result in respiratory depression, right? Unfortunately, the effects are widely variable and quite difficult to predict. And in fact, opiates, I think we've all seen, are the opiate overdose patient in the ED who presents with these large gasping breaths and large periods of apnea, which is quite different, really, from the way we set our ventilator for patients with ARDS, for example, with small tidal volumes and rapid respiratory rates. And you can see there's this discordance there. And unfortunately, the idea between respiratory depression and synchrony really hasn't borne out. Here's a small study of 20 patients with increased sedation. Actually, there's higher levels of ineffective triggering. And then similarly, here's a study looking at the propofol effects of synchrony of 14 patients. And they did find that while increased sedation decreased the neural drive and effort, at deepest levels of sedation, there's actually higher levels of ineffective triggering again. And ineffective triggering is clearly important, but I think what is even potentially more important are forms of dysynchrony that actually cause lung injury. And I think this kind of raises the point nicely with this idea of reverse triggering, which you may or may not be comfortable with. Dysynchrony from reverse triggering is this idea that there's neuromechanical coupling between the ventilator and the patient, meaning that the ventilator actually almost triggers a diaphragmatic contraction in turn, which can result in large breath stacking events and then large transpulmonary pressure swings and volumes. And this has been thought to actually be postulated to actually be uncovered and worsened by deeper levels of sedation as well. Indeed, this idea about sedation really reducing injury is also complicated as well. So in this nice study of 62 ventilated patients, they actually measured 4.26 million individual breaths. And they found that while dysynchrony was overall reduced by deep sedation, there still was large levels of tidal volumes associated with double triggering and flow limited breaths. And even this was found in patients with very deep levels of sedation as well. And then in this study that looked at 79 patients with over 14 million breaths, they actually looked at sedative equivalents versus opioid equivalents. And they found that sedatives, whether alone or combined with opioids, did not result in better patient-ventilator interactions than opioids alone in any ventilator mode. And they looked at, you can see in the top, there's a total asynchrony index, and then ineffective triggering on the bottom left, and then double cycling on the bottom right here. And what they also found is that higher opioid doses were associated with lower asynchrony index without depressing consciousness, and that higher sedation goals were administered, the sedative doses were only associated with less double cycling alone. And so the question from this was, should opioids represent the backbone for establishing synchrony? Maybe, maybe not. I think the jury is still out on this. And then when looking at propofol versus dexmedetomidine, they looked at 20 difficult to wean patients, and they randomized to receive sedation with either dexmedetomidine or propofol, and actually titrated patients to a similar RASS score, and then looked at asynchrony index over the initial 24 hours. And they did find that the asynchrony index was lower with in the Precedex group, the dexmedetomidine group, at 12 hours compared to the propofol group. And so I think a lot of this data is really still leaves us with questions about, we don't really know what the best way of preventing dysynchrony in our patients using sedation. It does, though, raise questions of whether or not these are the only mechanisms for preventing lung injury using sedation. And I think this is a nice tie-in to the wonderful presentations from Paul and Andreas earlier, just before me, that there may be other mechanisms for protection from sedatives as well, not just from preventing spontaneous breathing and dysynchrony. Ketamine is an agent that we've loved using, actually, increasing over the last year and a half with the COVID crisis. It started out as basic running out of other sedative agents because of how many ventilated patients we had. And then we found increasing benefits from potentially improved spontaneous breathing with less efforts, and then associated with other things like that we found in status asthmaticus patients as well, like decreasing resistance levels, work of breathing levels as well. And then, I won't dwell on this for too long because Andreas, I think, covered this in more detail, but volatile agents also have gained increasing use as well. And so here's a nice meta-analysis from 68 studies looking at propofol versus volatile agents in the operative setting, and there's a reduction in mortality, as well as a reduction in pulmonary complications secondary to volatile agents. Additionally, there appears, again, this benefit from the direct effects on the lungs itself, that patients may have improved airflow and decreased airway reactivity as well. And because of this may have a lot of benefit in status asthmaticus patients. And I've saved several patients from needing ECMO with status asthmaticus with combinations of ketamine and or isoflurane in our patients. But what's really interesting about these inhaled agents is that there may be direct anti-inflammatory effects as well, which is particularly of interest when we're thinking about the biotrauma in our patients and preventing lung injury from the sedatives that we use itself. It may decrease neutrophil migration. It may limit the release of inflammatory cytokines. And again, this is of particular interest in our sepsis groups, our folks that are at risk for ventilator-induced lung injury, trauma, pneumonia, et cetera. And I'm not going to go into all the detail of all the studies. There have been multiple studies that have looked at this, particularly in one-lung ventilation. You can see here that the red propofol group stands out here as having increased inflammatory markers in the alveolar lavages in 36 patients that were studied. And then similarly, Andreas, I'll cover this as well, but there's rapid recovery and waking up time, potentially decreases in time for mechanical ventilation. And then Andres' own study as well, which he already covered as well, which shows retrospectively that patients may have improved mortality, again, with all the caveats of a retrospective analysis. And then more recently, which was also covered as well, this idea that it may decrease in both inflammation and also improve P-DEF ratios in patients with ARDS as well. And then lastly, there was a trend towards improved mechanical ventilation time and length of stay, although again, this didn't meet statistical significance due to the relatively small numbers. And so I do think this is, volatiles are an exciting new pathway for our ARDS patients. One of the major limitations that we had in our COVID units over the last year and a half was the use of the actual anesthetic machines themselves for care. And it does really require independent ways of delivering the volatile anesthetics like the Anaconda device in order to be successful, as opposed to the traditional approach because of the limitations that are inherent to the anesthesia machines that we were using. But I think what's really what I want to get back at is this idea that when we're monitoring for sedation levels, it's how we actually monitor that really is important. Okay, regardless of what agents you're using, we want to actually make sure that we are achieving the desired effect on our patients with the sedatives. And I think we oftentimes are using really blunt instruments for assessing for sedation levels in our patients based upon the idea of lung protection. The RASS score does actually have obvious fighting of the ventilator included. This is scored as a +2, but there are really no other markers of synchrony or spontaneous breathing in this. And similarly with the Riker agitation score and other scoring systems as well, there's really not a good way of detecting or determining whether or not you're synchronous based upon the sedation level you're on or whether you're protecting the lungs. And really, these are, again, there's really been very little correlation between this idea between sedation and synchrony. Sedation does not equal synchrony, and that's really important for us to remember when we're titrating our sedative agents for patients. And so we use what we think is a more physiological approach at Beth Israel. I'm not going to go into the details of them too much, but essentially what we are doing is we use the pressure volume loops of the chest wall. In the central panel, we have a patient who's deeply sedated but not synchronous with frequent expiratory efforts. And then on the right, bottom right, we have a patient who's fully passive. And you can see that the patient's having inflation and deflation along the passive chest wall curve of the chest wall pressure volume loop. We don't need to remember all of the different breathing patterns. All we have to do is teach our nursing staff to show what this up and down line on the right here looks like. So it's very easy for patients to achieve full passive breathing, both with sedation and neuromuscular blockade if needed in our patients. Again, I won't go into this in too much detail, but here's a patient who's maxed on the ventilator, who's doing very poorly with frequent breath stacking events. The level of sedation is increased if it responds to me. And then slowly over time, the amplitude of efforts decreases, and then the patient becomes fully synchronous. All right. Again, this is limiting for a lot of centers because of the use of esophageal manometry and the right equipment. There are other nice ways of doing this as well, which we'll briefly get into. If you have a NAVA machine, the monitoring of neural diaphragm effort may be very useful in some centers as well to look at sort of degrees of safe breathing activity. And then the pressure time product as well, which is essentially integrating the inspiratory muscle pressure generation over time. Some ventilators are allowing for measurement of this as well in real time, or if you have specialty equipment as well. I think, though, it's kind of one of the more exciting ways of doing this, because most ventilators are actually having this available for use at the bedside, is this idea of using the airway pressure occlusion, the P0.1. This is the pressure generated that's by the patient over the first 100 milliseconds, and it can be used as a marker of spontaneous breathing effort in our patients. And this is now automated in most of the ventilators that we're using in critical care, with safe levels that have been sort of anywhere between 0 and -3.5 centimeters of water. And one of my good friends and colleagues that we're collaborating on our projects with, Jeremy Beitler at Columbia, has introduced this idea of respiralysis, titrating sedation to actually decrease respiratory efforts. So this is 56 patients with 197 bedside observations. They found actually in their two presentations of this that respiratory drive is not associated with sedation depth, that there's no correlation between P0.1 and RASS at any time point. And that some of the largest P0.1 efforts were actually in the patients with the deepest level of sedation. They did find, interestingly, that patients in this middle tercile of efforts had the most ventilator-free days, which raises the question of either too deeply sedating patients or not deeply sedating enough patients, that there may be a sweet spot for patients, although this is really preliminary. But I do think it kind of gives you this idea that titration of sedation to values like P0.1 may be really valuable in our patients with lung injury. So in conclusion, I'm hoping moving towards a new paradigm of lung protective sedation in our patients. And really, there's a couple of parts of this. One is that we have a better understanding of the specific sedatives and analgesics on breathing patterns themselves, that we have a better understanding of the breathing patterns themselves as being harmful or benign, which is still ongoing. And then we target sedation for the individual patient. And lung protective sedation might mean something different on two different patients, depending on what their primary issue is. All right? Do they need them to be fully passive? Then we should titrate sedation to fully passive breathing. Do we want to optimize dysynchrony? Well, this might be variable. In some forms of dysynchrony, we may be actually decreasing our sedation levels. And then lastly, if we're spontaneous breathing, then we should be titrating our level of sedation to synchronous, safe levels of spontaneous breathing for these patients. I do think that there's a great future in some of the non-standard ICU sedatives, including ketamine and inhaled anesthetics. We actually we're using phenobarbital as well during our most extreme cases of shortages during COVID crisis. And so I think reaching outside the box can be helpful in some cases as well. And then finally, this idea between balancing lung and diaphragm protection. I didn't get into diaphragm protection in too much detail in this presentation today. But I do think we need to have earlier and more consistent sedation reduction trials, the transition to spontaneous breathing as early as safe as possible, and then potentially even diaphragm training in some cases as well. So thank you very much for your time today. And if you have any questions, I'd love to take them.
Thanks a lot for this fantastic talk. Any question? I have a short one. Do you think that we need an asynchrony index continuous monitoring?
I do. The problem is that not all asynchronies are the same. And I think lumping things like ineffective triggering with breath stacking dysynchrony or flow asynchrony, which we didn't get into, which are, in some cases, they're more of a nuisance and maybe uncomfortable for the patient. On the other, they're maybe potentially really harmful, actually, for the patient's underlying lungs. I think that's problematic because different forms of asynchrony respond differently to different levels of sedation. Some are worsened by deeper sedation and some are improved. So I think having a single asynchrony index by itself misses the point a bit. I think we actually should be thinking about asynchrony indices, but maybe more in particular focusing on the asynchronies that are potentially injurious rather than lumping them all together.
As far as I know, a lot of studies about dysynchrony in the past have been done with volume-controlled ventilation with constant flows. Well, I think this mode is not really up to date. Can you comment on that?
Absolutely. So I think you run into different issues depending on the ventilator mode that you are on. And as Andreas so nicely brought up here, when you are forcing somebody into certain specific flow patterns with volume control or limiting their inspiratory time like you do in any control mode, essentially, then you are inherently going to change the interaction between the patient and the ventilator. The problem with spontaneous breathing is you lack the control of a lot of these parameters, which you're really concerned about in our sickest of sick patients. That being said, if you are careful in our monitoring of the breathing efforts, of the driving pressure in spontaneous breathing, of other markers of effort, then you can safely apply spontaneous breathing in those patients. I would say, though, that in our sickest of sick patients, even if some of the parameters are looking within safe levels, because of the inherent penduloof that is occurring in patients and the distribution of lung injury, that you may still be getting some lung injury that's worsened with spontaneous breathing simply because of the nature of the conformational change of the diaphragm and the contraction of the diaphragm in those sickest of sick patients. But I agree. I think that a lot of our information on this is relatively limited by the particular modes that we're looking at.
Okay, thank you very much. The next speaker is going to be Dr. Katarzyna Kotwis from Czechin. She's going to talk about the current place of sedation in RDS.
Thank you very much for the invitation. It's a great pleasure to be here and to be able to give a talk. I have nothing to declare, so just to start with that. Acute respiratory distress syndrome, we all know in the ICU, we treat it every day, 10% of patients, and that is associated with increased mortality. Now, in the first place, why do we need sedation for those patients? Obviously, to initiate mechanical ventilation, to adapt the patient to it, but also to reduce the mechanical power and the risk of ventilator-induced lung injury. But as clinicians and working as practical doctors, we need to concentrate on providing patient comfort and allowing the patient to tolerate all the procedures that we're performing in the ICU. So the ECASH concept that was introduced in 2016 has very nicely shown, has very nicely shown that humanitarian approach is the mainstay of our approach in the ICU, but some patients will need severe sedation, deep sedation. This is severe respiratory failure with asynchrony, as mentioned before, and those patients who need paralysis. We are guided by certain guidelines, which is the 2013 PAD guideline and the 2018 PADIS guideline, and both have introduced the concept of the preference of light sedation over deep sedation, which is not always possible for patients with severe ARDS. So why was the concept introduced? Because lighter sedation shortens mechanical ventilation time and provides the patient with better outcomes, less delirium, and less ICU-acquired weakness. But bear in mind that those recommendations have been made based on studies that included very few ARDS patients. Now, we know that deep sedation worsens survival. A study by Shahabi and colleagues have shown that very elegantly at 3 months after ICU stay, and so an introduction of spontaneous awakening trials and spontaneous breathing trials also increases patient survival when measured at 1 year, a study by Gerard and colleagues. So all the recommendations have been combined into the A2F bundle with the priority to provide comfort and analgesia, but also to target light sedation. Now, on the other hand, on the other part of the spectrum, we know, and that has been proven beforehand, that mechanical power is associated with survival. So the survival rate in those patients with low mechanical power was higher than those with high mechanical power, and that was directly associated with the depth of sedation. Patients with ARDS are very heterogeneous. This is a group of patients who need not only very customized ventilation, not very customized approach, but also very customized sedation. And it would be easy to say that the more complex interventions, the deeper the sedation, but the COVID-19 pandemic has brought a range of patients who will also need sedation, but will be awake and will be prone. So what about those patients? We will need to talk in a minute. A group of patients that definitely requires deep sedation just for humanitarian reasons, just to prevent those patients from being awake are those who are receiving neuromuscular blocking agents. So, but that also has to be titrated. So initially, when we, prior to administrating the neuromuscular blocking agents, the patient requires deep sedation, but after turning the patient into supine position, an interruption of the neuromuscular blocking agent infusion could be preceded, and so lightening of sedation. Now, a very interesting study that correlates the use of deep sedation in patients receiving neuromuscular blocking agents with mortality has been published by Karuna Vongtangtam this year, and it shows that the deeper the sedation in patients receiving neuromuscular blocking agents, and this is the clue, the higher the mortality. And those patients whose Richmond Agitation Sedation Scale was deeper than -3, so -4, -5, those patients had a probability of survival less than 50%. Now, a range of patients with ARDS will not require paralysis, and this is where protective ventilation comes to place first. And analgesia first, minimal sedation is the mainstay, or let's say the default options for those patients. And as the disease progresses from mild to severe, mild sedation might also progress through moderate to deep sedation. And this is an algorithm proposed by a group led by Gerald Chunk in 2020 on how to approach ARDS, patients with ARDS and their sedation. So the bottom line is to frequently monitor the need, review sedation at least twice daily, and assess those patients. Now, as I previously said, there are very few studies concentrating on patients with ARDS. Now, this is an analysis performed by Hugh and colleagues, published in Frontiers of Pharmacology this year, which included a very large number of patients, 17,000 of patients, and this is a combination of two major ICU databases. And they looked at the effectiveness, comparative effectiveness of midazolam, propofol, and dexmedetomidine in patients with ARDS or with risk of ARDS. And it has been shown that sedation with dexmedetomidine actually has a lower mortality rate than with midazolam and propofol. We are not surprised with the midazolam outcome, but not so with propofol. And obviously, no sedation is better than sedation with any agent. Now, another group within the very large heterogeneous ARDS patient cohort, those that will require prone positioning. Traditionally, we've been giving the neuromuscular blocking agents, although the evidence behind that is not entirely clear, and there will be ongoing talks regarding that. Maybe the NMBAs could be used just for the turning procedure and not used continuously. This is to be decided. But the 2016 study of the APRONET analysis has shown that it has been an observational study showing that 87% of patients prone with ARDS receive neuromuscular blocking agents. There might be a shift of approach with that. Now, what about those patients? And as I said, the COVID-19 pandemic has brought a change in this approach. We have patients with ARDS who are awake, intubated or not, who are being proned. And what about sedation for those patients? As we know, proning is very prone to pain, anxiety, and just high stress. So a study by Tabata, not including many patients, it's only 63 patients, but they have shown that dexmedetomidine given to those patients who are awake and proning is a good and obviously satisfactorily used option. And this has already been shown. Patients who are proned and receiving sevoflurane, now those patients were able to be switched to pressure-supported spontaneous breathing mode successfully with sevoflurane. Another range of the spectrum, or another potential problem, is those patients with ARDS progressing to needing ECMO therapy. Now, we have two major problems. One is what we all fear, the additional organ, so to say, provided by ECMO, and the fear of displacement and catastrophic fatal consequences. On the other hand, altered pharmacokinetics of all the drugs that we're giving. And there have been thought-provoking studies showing that we can actually perform awake ECMO in patients prior to intubation and change that thinking to a new era. Now, as I said before, ARDS in the pre-COVID and sedation for ARDS and mechanical ventilation and the approach to in ICU pre-COVID-19, we knew the bottom line that we need to target light sedation to improve patient outcomes, to improve, to decrease the number of patients with delirium. And now we're approached with a surge of patients with COVID-19. And so what has happened? We have seen, all of us in practice, but also in studies, that many of those patients, that the sedation needs for patients with COVID-19 and ARDS have increased substantially. They usually don't need, those patients usually could not be sedated with one agent. This is a study by Flinsbach showing that half of those patients were sedated with at least 2 agents and 1/10 with 3 different agents, combination of those that were previously discussed by previous lecturers. So another major problem brought by increased sedation use and increased sedation depth has been elegantly shown in the COVID-D study, which is a multi-center cohort study led by Brenda Punn, showing that during the COVID-19 pandemic in those patients, we used more midazolam, and that was linked to more delirium, and the brain dysfunction that was already ongoing has actually been increased. There were other factors identified, like lack of family visitation, but the use of deeper sedation with midazolam, with benzodiazepine, was a major factor. Now, another COVID-19 study showing, by Corona Von Sumten, showing that as soon as the pandemic started, which is the last three bars, March, April, May 2020, the average daily sedative infusion dose in those patients increased during the COVID-19 pandemic. This was statistically significant, and this was also linked to mortality. Mortality in those patients was associated to greater percentage of coma and higher mortality. And the reason for that was higher mortality. So what is the solution? This is a very elegant ICU liberation strategy for ARDS patients proposed by Gerald Shang and a group of experts, showing that we should concentrate in patients with ARDS, we should concentrate on the ventilation, prioritizing respiratory efforts and controlling respiratory drive, but that should be done twofold. One is to assess, prevent, and manage this on the patient side, but also to adjust the ventilator settings and allow spontaneous breathing as soon as possible. Now, there are some physiological factors that we need to adjust on the patient side, which is hypothermia, acidosis, or hypercarbia, but just following the guidelines that were shown to us as the PAD and the PADIS guidelines, and just adding one extra element, hopefully, will be the explanation to reduce mortality in this group. So just to conclude, sedation in patients with ARDS is very challenging because that's a very heterogeneous group. The goal, obviously, is to liberate the patient from mechanical ventilation as soon as possible to restore their normality and physiology. And the mainstay has not changed. The bottom line has not changed. We should provide those patients with analgesia first and add on sedation as needed. Now, to avoid unnecessary deep sedation, we should monitor the sedation depth, either with RAS or SAS or electroencephalogram-based monitoring, whatever will be feasible. But this should be done to remove the burden of the deep sedation and to control the respiratory rate first. Now, we obviously need more evidence and actually randomized controlled trials, or at least observational trials, to see if this approach, the A to R bundle, works. But this is a very promising option, and I thank you very much for your attention.
Any questions from the audience? Yeah, please.
In the study, you showed us with the correlation between mortality and levels of sedation. Would that maybe reflect severity of illness, severity of ARDS, bad oxygenation, that would require increased sedation and would lead to increased mortality? What is your opinion? Thank you.
Thank you very much for the question. This is a very important topic. Obviously, there is a range of patients in which the severity of illness is mimicked, and we just, with the severity of sedation, we follow the depth of the disease. But that is not always the case. The study that I have shown by Karuna Wongtangman has shown a comparison between different group of patients, between the COVID-19 patients and between the patients with ARDS prior to that era. That was a comparison. And now it has been shown that at the same, let's say, disease level or the advancement of ARDS, the deeper sedation provided to those patients with COVID-19 has increased mortality. And there are other factors behind it, not just the severity of the disease, that have been identified. One of those factors was the personal fear from patient extubation, and also the changes in the sedation behavior that we introduced due to drug shortages, due to lack of personnel. So that study does not, if that answers your question, that study still tells us that we should lighten the sedation, and it is not always associated with this disease severity, but actually with what we do. So let's say this is a iatrogenic inflicted injury to those brains. I would put it that way.
Thank you very much.
Thank you.
So let's go on for the final talk. It's a pleasure to invite Dr. Wesley Lai from Nashville to explain us which patients could not be sedated.
Good morning, good afternoon. My name is Wes Ely. It's a great privilege to be here. And I have to say that following these previous speakers, I have a challenge because they've done such a great job in covering this topic. And I also know, though, that we are near out of time. So tell me, what time is this session ending? 10 minutes. 10 minutes? Okay, is everybody willing for me to go through the slides, or would you rather me give you a summary without slides? I can do it whichever way you wish. You want the slides? Okay. Again, my name is Wes Ely. I'm from the United States. I just arrived on an airplane less than an hour ago in jeans and a t-shirt, so I ran to the hotel, changed clothes, and ran here to be with you. I have nothing to disclose in terms of honoraria or monetary agreements with any pharmaceutical companies that will have anything to do with this talk. This is a slide that I ripped out of a journal many years ago. It says, diffuse anxiety infuse Versed. Most of you are too young to know. You can see that I'm old. I'm an old intensivist, been practicing for 30, 35 years. And we used to have everybody profoundly comatose on Versed. This ad was made by a drug company because we thought we had to diffuse anxiety and infuse Versed in every patient. It was essentially putting a chemical cast onto the body, which makes me ask you to prompt a question in your mind. Are you there to take care of a disease, a single disease, or are you there to take care of an entire person? And if you're there to take care of an entire person, then we have to ask ourselves, what's the cost of doing this to our patients? Because we know that delirium is a canary in the coal mine, under-recognized form of organ dysfunction. The majority of our COVID patients now, 90% in some reports, are delirious. And this triples the risk of death at 6 months independently. We have multiple studies showing this. And every additional day of delirium increases the risk of death by 10%. The story I'm going to tell you is one of a journey that we've been on the last 15 years to try and give ourselves tools by which to provide the lightest sedation possible. We started in 2007 with this paper called the MENDS study, M-E-N-D-S, like mending the brain. It was the first randomized controlled trial by which a alpha-2 agonist was placed up against a GABAergic drug and shown with delirium as the primary outcome to have improvements if you avoided the GABAergic approach, which essentially was avoiding a prolonged, deeper sedation approach. This is a picture of one of our patients last week. You can see she writes on her chart there, "Take the damn shot." So it's a dual message here, which is let's improve our vaccination rates around the world. But also, this woman was recently intubated with COVID, and you can't see her ventilator settings, but she's on 100% FiO2 and a PEEP of 18. Let me say that again. This is a COVID patient on 100% FiO2, intubated with a PEEP of 18. Does she look like she's in a coma? After we took this picture of her, and she does need to learn how to spell the word damn, by the way. After we took this picture of her, the respiratory therapist and the physical therapist came up and said, "Can we walk her?" And we said, "Absolutely, that's how she'll get better." So this is a wide awake, 100% FiO2, PEEP of nearly 20 patient walking on the ventilator in our ICU with COVID. There are lots of ways to approach sedation. What you're doing is saying, how do I best care for this entire human being? If I have dramatic asynchrony, if I absolutely require neuromuscular blockade, then clearly I need a deep sedative for the time being. What I'm telling you is that the concepts that Dr. Kotfus just went over with you, those concepts that she reviewed with you, are way more important than anything I'm about to say. She did all the heavy lifting in her lecture, which was, let's wake people up, let them be a human being. If I don't, what's the cost? The cost is that I can't tell what you need as a person, as your physician. I'm there to take care of all of you, and yet I completely mask and thwart my ability to know what it is that you need if I put you in a coma. Not to mention all of the acquired diseases that accrue, like neuromuscular diseases, acquired dementia, bed sores, etc. So, no sedation is the best approach. Thomas Strom, Yahya Shahabi's work, as we learned earlier with light sedation. What I'm going to offer you is our recent New England Journal paper, in which we randomized Dex versus Propofol. Why did we ask this question? We asked this question because after the MENDS study, the one I originally showed you, we learned that the alpha-2 agonists appeared in septic patients to have a survival advantage. Back in 2007, we were heavily sedating patients, and when we shifted from heavy sedation to light sedation with an alpha-2 agonist, there appeared to be a survival advantage in the alpha-2 group. Was it because of the alpha-2, or was it because of light sedation? In the meantime, Yahya Shahabi has shown us that deep sedation is increasing the risk of death. So it could have just been in MENDS 2 that the survival advantage was a lighter sedation approach, right? And that essentially will be the answer I'm about to share with you. In this New England Journal paper, which we did to see if alpha-2 agonists saved lives, all of the patients were treated with light sedation. An entire culture change, a shift in the way we handle patients had occurred, and at the end of the day here, we do not see a difference in GABAergics and in alpha-2 agonists. I'll show you the data quickly, but if you compare, I'm trying to give you some take-homes that you won't get from the papers. If you compare this study with the SPICE-3 study in the New England Journal, what you will see are two completely different approaches to handling sedation. In SPICE-3, you have a population of patients who are treated in a culture of deep sedation, much deeper than this, and in this study, which is called MENDS 2, MENDS 2, you have a culture of lighter sedation. In fact, some people argued that we had not tested our hypothesis because we didn't use enough propofol. But we used whatever propofol was required to get the patient to light sedation. So let's quickly go through what we did. Double blind, we masked the bags, because Dex is milky, Propofol is milky. So we did all that we could to blind the circumstance. I'm going to go very quickly now because we need to get you out of here. Very high severity of illness. In fact, this is another great take-home point that I think a lot of people have missed. In SPICE 3, in which they were deeply sedated with gargantuan amounts of propofol, even though they randomized to Dex versus usual care, in the Dex group, 65% of patients got large amounts of propofol. Those patients in SPICE 3 had Apache scores of 22. These patients had Apache scores of, where is it over there? 27. So this is a more sick group of people with lighter sedation. Think back to the picture I showed you a minute ago of the COVID patient on 100% PEEP of 20 and wide awake. This is just a matter of what are you going to do as a physician at the bedside? Which culture are you going to adopt? So 2/3 medical, 1/3 surgical, and they were enrolled that first day randomized. Key points. We started the drug on that first day. They got it for a median of 3 days. The median RAS was -2. Many patients at RAS 0. Median sedative doses were low. In fact, some people criticized the study because they were so low. Sorry, we chose to lightly sedate our patients. Very high rate of what Dr. Kotfus just went over with you, A to F bundle compliance. In fact, in this study, it was A to E bundle, but the A, B, C, D, E bundle, 85 to 98% compliance. That's the ticket. It did not matter what they were treated with. It was that the approach was one of every single day, stop the sedatives. Every single day, test their need for the ventilator. Get them out of the bed, walk them, and address their delirium. When you do that, and those are just the median RAS scores, I'm going to get us to the answers here. You see there is no difference between Dex and Propofol on the A graph, top left. That's days alive without delirium or coma, so delirium coma-free days. And out of 14, they had 11 days without delirium and coma. In Apache, 2 scores of 27, all septic, and they only spent 3 days median in any form of brain dysfunction. That's pretty remarkable. Ventilator-free days, 24 out of 28, and then the TIC scores, the long-term cognitive function at 6 months, even between the two groups, about 1 standard deviation below normal. No difference in mortality. I'm going to skip all this and just bring this to a conclusion here. In ventilated patients with sepsis being treated with recommended guidelines, the PATIS guidelines, it does not change the outcome whether or not you use the alpha-2 or the GABAergic drug, as long as you adhere to a culture of light sedation, which is endorsed by the international SECM guidelines of PATIS. And the way to do this is something you're going to have to figure out. You're going to have to ask yourself, am I willing to keep my patient in a coma for multiple days because it's convenient to me, or am I depriving myself of the ability to see this person as they really are, look them in the eyes, communicate with this human being, and find out what it is that they need me to do as their physician? Thank you so much. I appreciate your attention.
Thank you for this fantastic talk. Any questions? No, one question there.
Thank you very much for a brilliant talk. I was just wondering, how many days after the intubation did you have this patient awake?
Did you say how many days after ventilation would I have this patient awake?
Yeah.
Yeah, immediately after I intubate somebody, I start asking myself, is this ventilator still required? So I used to, as a young intensivist, put the patient on the ventilator on a Monday and think, well, gosh, that's what they needed on a Monday, so they probably still need it on Tuesday and Wednesday. Now I think to myself, the ventilator is a death box. The second I get them on the death box, how quickly can I remove the death box? And so I immediately start removing anything. The arc of critical illness is like this. Here's increasing critical illness, leveling off of severity, and then removal. The big difference of critical care in the past 20 years is that we used to remove things over here on day 5, day 6. Now we start removing things on day 1, day 2. So it's immediate. I know we're late, and I appreciate all your attention. I don't want to keep you late. Thanks so much. I'll stay up here after if you have any questions, and I'll see you the rest of the meeting. Thanks so much.